Good afternoon. Thank you for joining us for today's webinar, COVID-19 Response in the Primary Care Safety Net. I'm Eileen Selinsky, Program Advisor at Grantmakers in Health, and I'll be moderating today's discussion. Federally qualified health centers, FQHCs, and other primary care safety net providers are playing a vital role in response to the pandemic. These essential providers are serving as shock absorbers for hospitals, focusing on screening, triage, and testing where it is available, while also continuing to provide routine care to patients. This webinar will explore how primary care providers are addressing COVID-19, the key challenges they are facing, and the ways philanthropy can best support response and recovery efforts. We are joined today by 5 terrific speakers from the National Association of Community Health Centers, or NAC, Dr. Ron Yee, the Chief Medical Officer, Malvise A. Scott, Senior VP for Partnerships and Resource Development, Jason Patnausch, Associate VP for Partnership and Resource Development, Jennifer Taylor, Director of Federal Affairs, and Susan Burton, Director of National Grassroots Advocacy. Following a facilitated discussion with the NAC team, 2 GIH funding partners, Brenda Sharpe of the Reach Healthcare Foundation and Steve Lesky of the Cambia Health Foundation, will briefly describe how their foundations are working to support the primary care safety net during this crisis. Before I turn things over to our speaker panel, I need to cover a few quick housekeeping items. Our call will be an hour long. The call is being recorded and it will be posted to our website along with slides and additional resources in the next few days. I do want to remind our attendees that we are making our COVID-19 programming publicly available. So the slides and resources will be available to all through the GIH website. And I do want to remind folks that all participant lines have been muted, so to just ensure call quality during the course of the webinar. If you have any questions or comments, please feel free to enter them into the question box, not the chat box, the question box, at any time on the webinar control panel located in the panel's lower portion. Following remarks from our speakers, we'll do our best to answer all of the questions that have been submitted. If we don't have time to get to everyone's questions during the webinar itself, we will follow up with you to provide answers after the webinar has concluded. Please be aware that, like many organizations, we are running these webinars from our homes. We apologize in advance if there are any technical difficulties. Please bear with us and we'll get through it together. The best advice that I can give is that if for some reason your call falls off, please dial back in. So without much further ado, I want to turn to the team from NACCHO for a brief interview that we've prepared. So Ron, Malvise, Jason, Jennifer, and Susan, thank you so much for taking time from what I'm sure are very busy days to join Grantmakers in Health and our funding partners for this important webinar. Let me start with a two-part question for Dr. Yee. How is the COVID-19 pandemic affecting demand for and provision of services at community health centers across the country? And what are the biggest challenges CHCs face in responding to these changes?
Thank you, Eileen, and I want to thank GIH and funding partners for taking the time to listen to us, what's happening on the front lines at community health centers. I'm a family physician and I served 20 years at a health center in the Central Valley of California, caring for farm workers and their families. So on behalf of the 12,000 sites and 29 million patients and over 235,000 employees at health centers, thank you so much for taking the time to listen to us. So the question about how this is affecting demand and provision of services and what are the biggest challenges, I'm going to break it into 3 sections, which we're seeing on the front lines, and we're daily in contact with them and have had national webinars to address these issues. But first of all, number 1, personal protective equipment and testing supplies. Number 2, staffing and operations. And number 3, finances on the front lines. So the personal protective equipment and testing supplies have been totally stressed, and it's very geographically affected right now. As you know, New York is in the middle of it. Washington and California have been through some of it, and the other ones are gearing up. There are other states like Louisiana that are having big impact, in New Jersey as well. So according to early survey results, about 70% of health centers are experiencing issues related to running low or running out of personal protective equipment, or they're having major problems with obtaining supplies. So they've been trying to work very closely with their supply chain partners and also seeking to access the national stockpile. But this comes down to a state-based approach where you work together with the emergency management agency as well as the governor. So about 70% are doing COVID-19 testing, but also running low on testing supplies. So many are getting pressed right now on their supplies and PPE. This is a really primary concern for the staff on the front lines, even because they're seeking to limit exposure to possibly infected patients, whether that be in the registration, checking vitals, examination, testing, or discharge processes. People are being exposed, and so they are trying to do their best to apply CDC guidelines, trying to watch how they use the PPE to conserve it, but also protect the staff. And many of them are moving into telehealth electronic means, but there's still many who need to be seen. So they want to stay on the front lines to provide care, but many fall into high-risk categories, such as age, high elderly, pre-existing conditions, or immunocompromised situations. And so it's a real struggle for people on the front line to maintain their mission and purpose, but also think about protecting themselves and their families as healthcare workers. So the first one is PPE and testing supplies are the challenge. Number two, staffing and operations are really an issue on the front lines. We're losing staff that need to care for their children out of school since they've closed. They've either been exposed to or tested positive for coronavirus themselves. And this takes them out of service for 14 days at a time. One health center in the District of Columbia is down to about half to a quarter of their usual staffing because of people either being exposed or testing positive for coronavirus. And most of them are switching to virtual visits and telemedicine, but operations are being stressed as these health centers are having to try to segregate patients, the well ones, if they can, designating specific sites to take care of well patients, such as obstetrical patients, children who need to be immunized, patients who have chronic disease that are kind of on the edge with their diabetes, hypertension, their congestive heart failure. They still need to be seen. Many of these need to be examined. So they're struggling to figure out how do we maintain these visits, but also take care of people that are walking in that have symptoms of coronavirus and need to be evaluated and assessed. These patient flow and workflows have really been changed due to infection control measures and seeking to apply CDC guidelines. So this has stressed the staff dramatically in terms of patient flow, what they're used to, concerned about their own families and their own health. And so it's always challenging to find that balance of staying on the front lines, improving operational efficiencies, and to use PPE appropriately to minimize exposure while conserving and fearing taking this home to their families and loved ones. So that's staffing and operations. And finally, finances. 95% of health centers are seeing a decrease in patient encounters, of course, due to having to cancel routine visits, physicals, and non-emergent care. Now, many of them are only doing emergency dental care and are down to minimum visits. On the average, health centers are running about 50% less than normal capacity. So that has really cut down and affected their revenue generation and cash flow. Now, most are switching to virtual visits and telemedicine, but this is only a fraction of the reimbursement they usually receive from Medicaid and Medicare and other sources. So really are experiencing some major revenue shortfalls. A small health center in Minnesota has estimated that the COVID-19 response is costing them about $25,000 a week. And this is a small center with 6 sites. This is about $100,000 a month. On top of that, they're losing 50% of their revenue due to decreased visits overall. So these are the challenges that we're seeing on the front lines and hearing every day about PPE testing supplies, staffing and operations, how it's affected them, and then the finances.
Thank you, Dr. Yee. That's helpful. Can you talk a little bit about the longer term implications of the pandemic for CHC operations and financial viability?
Yes, Eileen, and I've broken these into three areas, kind of being a clinician and knowing how things run. I'm going to break this answer into three areas of clinical, operational, and financial. And the long-term implications, getting through this is the challenge the next how many weeks or months. But some of the questions as a clinician that come up in my mind really is how do I maintain continuity of care, especially with my chronic care patients who I've cared for 10, 20 years, the immunocompromised, my patients who are on substance use disorder or opiate use disorder treatment, people who are receiving medication-assisted treatment and therapy, mental health patients, people who are depressed and anxious. And on top of that, seeking to maintain care for those who really need to be seen, as I mentioned before. We still need to see our obstetrical patients who are due to deliver, children who need immunizations to protect them from any future or communicable diseases that we can prevent. And then others that I'm really concerned about is people who are on the edge that are decompensating due to their diabetes, hypertension, asthma, heart failure, depression, and anxiety. And as a clinician, that really weighs on us that all this work and time we put into getting people under control or close to control, we're now losing contact with them or only having possibly audio contact over the phone, which you're trying to do, or depending on the state, if you can be reimbursed for telemedicine visits. So the question with this is the long-term implications is what will this do to our patient care and the continuity of care that health centers are so good at caring for people over decades. Second of all, operationally, we are totally forced into new models of care. So people from the dental department, behavioral health, they're now checking in patients. They are doing virtual visits, calling people to just find out how they're doing. And so as we move into the recovery phase, we ask the question, what do we retain? We have learned some things about virtual visits, which I think can be used be helpful for us in the long run. But then what do you go back to? How do you find that right combination of seeing people in person? And what did the patients really desire? I had many elderly patients who came in just to see me, even though they were well controlled, because they needed the social contact, or they needed the security of knowing someone's there physically to listen to them and care for them. So I think going on, that's going to be one of the big questions is, do you shift all of your staff back to the prior functions? What does that combination look like with new models and approaches? I think operationally, the other question is, how do you stay financially solvent amidst this extended pandemic response? What has happened to your staff that you've had to either lay off, furlough, or let go completely because you've not been able to stay alive financially and your cash flow is so down? Have they found other jobs? Have they gone into other fields, taking care of their families and seeking to have ends meet? On top of that, you throw in training that health centers do a lot of, who train nurses, medical assistants, physician assistants, nurse practitioners, and physicians and dentists. And also those that have the National Service Corps recipients who are there for commitments of time. On top of that, you throw in residency programs for medical doctors teaching health centers. And so what happens because of COVID-19, you've disrupted their whole training model and the flow and pipeline of clinicians and staff that flow into health centers to help meet some of our workforce needs. Those are big questions on our minds operationally. Not only what does that do to our day-to-day operations, but what does it do to all the training programs that we've built up over the years? So this pandemic's really disrupted our existing staff and interrupted our pipeline of training for future doctors, nurses, physician assistants, and other staff critical to fulfilling our mission. On top of that, we're seeing more and more patients, and the estimates, I think, from the Economic Policy Institute, they're estimating about 14 million people losing their jobs by the end of summer 2020. So these are more patients that are coming in to access care through health centers. What's that going to do to our payer mix? Are we going to be able to take the new capacity and have the capacity to take on new patients and see more patients that are trying to access the system? So those are some of the operational issues that we have, not only on the front lines, but also training wise. And finally, financially, as I mentioned before, can you even survive this? Health centers are struggling right now. Some are closing down, actually. If you even survive this, will you be able to keep going, even though you've had to close down sites, lay off staff, furlough staff? Many of them are cutting back on services such as dental, optometry, mental health, as I mentioned before, substance use disorder. So what does this do to the entire organization, and how does this affect you in the long run? If you survive, the question is going to be, do you have enough cash or assets to borrow against or to receive federal support to get back up and running? Or are you so deep in the hole financially that you can't recover or can't wait for federal support through the SBA loans, resources that are slow or challenging to access? I think it's going to take decades to recover financially, if we can at all, in many health centers. And as I mentioned before, new patients who have lost their jobs are going to be seeking access to care. Those in Medicaid expansion states might have a shot at it if these patients can qualify to enroll. Those in non-Medicaid expansion states are basically going to add to our uninsured rates, which runs about 23% all health centers in 2019. So are we going to be able to sustain this financially? So I think those are the main things that I think are really affecting us in the long run. Is, can we take care of our patients clinically and maintain those people we've worked so hard to get under control? Operationally, can we handle changes with our model of care and the training that we've been doing? And finally, financially, if we sustain this and survive, can we get back up and running in the end? So I thank you for asking these questions, and I think these are critical to all of us on the front lines and at the National Association of Community Health Centers. So I appreciate you asking these questions today.
Thank you, Dr. Yee. Your responses were quite informative. I'm going to turn the next question to Jennifer and Susan. I know you've both been spending a lot of time lately tracking what's been happening with federal policy changes. And I'm wondering if you could summarize for us how recent federal legislative activity is likely to impact community health centers' COVID response capacity, and kind of what additional policy changes you think might be necessary.
Hi, this is Jen. I'll go ahead and jump in first, and Susan, by all means, please feel free to add anything I missed too. First of all, I just appreciate the opportunity to be here, and it's always great to be working with Dr. Yee, because I think he really laid out the issues so well. I think these are the things that health centers are struggling with, and that we've tried to convey to Congress, need to be addressed in their efforts to try to provide relief to communities. And so what we've seen so far, obviously Congress has passed 3 major pieces of legislation, and we believe more to come. I'll just kind of quickly summarize what I think are the most significant components of those bills to help address the issues health centers are facing, and then also, where we maybe have some gaps. So far, a total of $1.42 billion has been set aside for health centers to go out through their 330 federal grant funds. Those dollars are designed as supplemental awards specifically for prevention, diagnosis, and treatment of COVID. We also have had some clarifying language that efforts to maintain current health center capacity and staffing levels throughout this emergency are included as sort of prevention, diagnosis, and treatment components. So there was some effort to try to assist with some of the staffing issues that Ron laid out. That was $100 million in the first package, and then $1.32 billion in this third package. I'll be honest, one of the challenges that always happens when Congress puts funding out is once the dollars, go out the door from Congress's perspective, they're thinking, okay, well, those dollars are in hand, but it takes time to get through the agencies and out to the actual entities in need, as you know. So health centers are just now receiving that first allotment of the $100 million that went out, that was announced last week. We are hoping that HRSA will move quickly to be able to get this next investment of $1.32 billion out. But we know there's still going to be outstanding need even beyond these dollars. Again, I think as Ron laid out, there's places where we're hearing people are losing, multiple millions of dollars a week. And certainly as this continues to unfold, potentially even more than that. So a good initial investment, but we are going to be working for additional funding. They also did provide a short-term fix. We have something that we've kind of referred to as the primary care funding cliff. It's where we have mandatory funding provided for a community health center fund, as well as 2 critical workforce programs, the National Health Service Corps Teaching Health Center program. I think this is important to talk about even in this space that is specific to COVID, because the reality is health centers were already facing this loss of 70% of their grant funds. So there was already some uncertainty and instability happening out in communities. And now those same health centers have been hit with these challenges. And so it is important, we think, for Congress to shore up this long-term funding. As Ron said, this is going to take years for them to recover from, and we want to at least restabilize this fund. In this most recent bill, Congress included basically about a 6-month extension through November 30th of 2020. We were facing a deadline of May 22nd. Obviously, we're glad that health centers don't have to be looking at a May 22nd funding deadline right now, but still having 70% of your grant fund on the line, in November, this is still a very challenging time. So again, more work to be done there, though we were glad for at least some initial acknowledgement that needs to be included in a response. There was also significant action around telehealth. Again, I think Ron really clearly laid out the need why health centers are utilizing telehealth, both to be treating patients who are sick with COVID, but really even more than that, to be able to treat their ongoing patients, those who are chronically ill, those who are over 65, those who are immunocompromised, to keep people at home when at all possible. And so we were glad to secure some better Medicare reimbursement for telehealth, essentially allowing reimbursement for health centers who serve as distant sites. So that's basically that the provider can be somewhere else serving patients at home. And we're actually working to clarify that the provider doesn't even have to be within the 4 walls of a health center, because as Ron said, we're going to have situations where providers themselves are exposed. So we're trying to continue to just broaden the approach to telehealth to provide reimbursement and to allow flexibility for both patients and providers to be in different locations than you would otherwise expect them to be. For the purposes of this bill, that flexibility was only provided for the duration of the crisis. Obviously, we are hoping to build upon that in a more permanent way, because I think this will take a lot longer to figure out. And we're also looking for appropriate reimbursement there. So one thing specific to health centers, we do have our own prospective payment system reimbursement rate. In this case, when we're talking about Medicare, it's a set rate for all Medicare visits across the country. And, Congress did not reimburse for these telehealth visits at the same rate as the face-to-face visit. So while we're glad to see some reimbursement, we don't expect that it will come in at our full rate. And that means health centers are still going to be taking a loss on these visits compared to what their normal intake would be. So again, we want to work with Congress and with the administration and whatever flexibility they have to ensure that the payment they receive is on par to what you would receive to a face-to-face visit. There's also things that are slightly less specific to health centers, but we think will be helpful. I think of interest to this group in particular, there's 2 big pots of funding. One of them is this new $100 billion fund to help healthcare providers offset revenue loss. We know that fund is going to be very important, but there's also not a ton of clarity so far on how that's going to be distributed. We know in that same pot are going to be, hospitals, public entities, Medicare and Medicaid enrolled suppliers, all kinds of, private physicians, any number of health provider groups that didn't have any specific set-asides in the rest of this bill and will be really focusing their efforts on this pot of funding. So we are grateful, again, that health centers are included, but have heard a variety of concerns from health centers already who feel that we may, get left behind in this, and particularly when hospitals are going to be coming in with probably big financial needs as well. How well are health centers going to fare? How is this going to be set aside? So still questions there. And then the last big one I wanted to highlight was this new SBA loan program, this Paycheck Protection Program through the Small Business Administration. I think this will be certainly useful for health centers who are looking for support in terms of payroll, helping make up for employee salaries, sick and medical leave, mortgage, rent, a variety of things. We know these loans can be fully forgivable if you meet the criteria. That they are also only for health centers with less than 500 employees. Certainly that is many health centers, but there are others who would not qualify. So again, outstanding need will remain here, even though this is a good first investment. The last piece I'll just touch on in general is that there are a variety of other things that we care about in this bill. I think attempts to try to address supply shortages and the PP issues Ron was talking about, but nothing specific to health centers and really no guarantees legislatively here on what happens next. There were things like investments in the Child Care Development Block Grant to try to provide assistance for healthcare employees to utilize child care, but again, we know that remains to be seen in terms of implementation, how helpful that will be in making its way to health center providers, and we've heard a lot of need around child care and concerns about how this is going to work. There were, investments, a couple of health and human services and social services programs that are important partners. Health centers obviously are very good at partnering and leveraging existing resources with those partners, but more work, I think, and clarification needed on how that's all going to come to pass. Those were the big ones. I think, we appreciate any additional efforts to kind of think creatively how to address the many problems Ron outlined, and to also know that we need to stay nimble because this is only going to continue, and Congress sometimes isn't quite nimble enough. Sometimes they're just coming around to address an issue that came up, weeks ago, and by the time they pass that legislation, we're going to be on to another issue. So really appreciate the interest and dedication of folks on this group to thinking how to be nimble with us and how to creatively meet the many, many outstanding needs that health centers are going to have in the weeks to come.
Thanks,
So
Jennifer.
this is Susan Burton. Oh, sorry.
I'm sorry, go ahead. I was just going to turn it to you.
Thank you. I was trying to save a little bit of time for y'all. I appreciate all of you being on here and your support for community health centers, and particularly for people in communities that are medically underserved. I'm going to have a little bit of a different ask, and part of it is having worked with funders for many, many years. I know the impact that you have in terms of making policy, creating policy, and using your voices in addition to the funds that you have to encourage different ways of thinking and being. And so we, as you might imagine, our strongest advocates are those that are directly connected to community health centers. And they're also the ones right now who are trying to care for their families and stay safe and look out for their patients. And as you heard Ron say, there's some health centers where the medical staff are not able to be on site anymore. So we need to ramp up additional advocates who will speak up for community health centers. And so this may be a different ask, maybe not. But I know that we're seeing lots of different people taking action and responding in a political way right now, and an advocacy way, so that people who need funding are getting it. And there are lots of news stories being generated. I would say that based, what Jen and Ron said rings true, in that often hospitals have larger stories, are out there, have larger needs, and are out there and more vocally because people know to look for hospitals. But we would ask that you would also speak up for community health centers and to remind people of the unique role, both in preventing the spread of the coronavirus and also being present to people who are losing their jobs and are newly uninsured potentially, and then also caring for patients who need the treatment afterwards. And so we know that there are lots of ways that people are pitching in an emergency fashion. Community health centers they are a part of the community day in and day out, and we need that to continue. So in addition to thinking creatively about how we solve these solutions, we would really greatly appreciate if you would go to hcadvocacy.org, and there you will find the different policy asks that we have. And if you sign up, you'll receive action alerts. You weighing in makes a big difference and will help those folks who are on the immediate front lines a great deal. So thank you so much for considering this and for having us today.
Thanks, Jennifer and Susan. A couple of clarifying questions have come in through the question box. Folks are wondering if you have some written summaries available that really sort of describe some of the things you've talked about with the federal legislation. So obviously a lot of moving parts, and I think folks are hoping that there might be some written resources available to clarify.
This is Jen. We do have a variety of resources, and I think we're happy to share them. We actually have a COVID page that NAC has put together And I was going to just check and see if we can send something in the chat box. Maybe Jason Patnosh, we can work to do that. And I also do have a specific summary that we pulled from all the various summaries floating around on this most recent bill that kind of hones in on the issues that we think are most specific to health centers in the bill. So happy to share all of that.
Terrific. And we can also find ways to send it out to folks.
Perfect.
The one thing I would add is that we're hoping that there'll be additional funding in a fourth package, because as you heard, health centers are closing right now and we need Congress to respond immediately. And so we're hoping there'll be significant funding. So that fourth package is a way that you can respond proactively.
Terrific. Thank you. So I'm going to turn now to Malvise and Jason. We've been focused on public sector response. Let's turn now to philanthropy. How can health philanthropy best support CHCs now and in the coming months?
Let me, this is Malvise, indicate as we've been through this first part of the crisis, I look back at my experiences as a health center employee, as a CEO for 17 of the 20 years I was at the organization. And I thought things were bad sometimes then. This is so much worse and so much more stressful for the staff, the patients, the board members, and the community, for those people who have been getting care at the centers. So this is difficult for many people and terrifying for others. One of the things that we have to recognize, and I try to share with potential funders, that the needs of health centers vary, and that is not different in this situation, but they do vary. And while the practices are funded by the feds under Section 330, there are significant changes, significant differences in patient populations, the size of these entities, those that have reasonable access to non-federal resources, local partnerships that they have developed, and get support. And I bring that up to say that these are not cookie cutter entities. There are different needs, and it's important that funders recognize that the needs may vary. Some people need cash, some need supplies, equipment, but it's important that we know that. What I fear is that there may be more local mergers of health centers, but there also on the other side may be more formal partnerships that are developed and help health centers survive over the long haul. Specifically with what would be helpful with grantors is that if they have a specific focus or interest, they should be specific about that. What the requirements are, what programmatic activities they expect or will permit the health center to determine, what administrative and reporting requirements there are. It's important that they know that, the centers know that, and that the funder is fairly specific about what the needs are. There will be times when a grantor has specific focus and is not explicit enough about what that is, what they want, what their expectations are. And that will only serve, even if they fund an entity, that will serve to only make their entity's life more difficult. I expect that, as my colleagues have said, this is not over by a long shot. Whatever happens in the next 6 months, 8 months, with regard to the pandemic, the health centers will spend many years surviving this. And we hope that we will be able to continue to provide services to the people in our communities that need it. We can only do that with not only the federal support, but the support from grantors, lenders, and others to make it work. Thank you.
And I'll add, thanks, Melvis. I'll add to that. I think Melvis hit the nail on the head in really thinking about that stability and flexibility first and foremost, and applaud many in the philanthropy sector right now who've already taken those steps of working with your current grantees. I know we've received calls from our funding partners about the flexibility and how the stability going forward. We'll be there for that. In touching upon, though, as you're looking at new potential dollars or how to redistribute some of those flexible dollars, you know, Ron and Jennifer and Susan touched upon it, where we're seeing the cash shortfalls right now in the revenues, where there are opportunities, maybe whether it's through program-related investments or new grants to cover some of those shortfalls, could be helpful to health centers right now. Zero interest lending opportunities are things that are helpful, especially with those that are at that over 500 employee level that Susan pointed out that wouldn't be eligible for the SBA and the Paycheck Protection Program. That covers larger health centers, but also larger amounts of patients. I think upwards near close to about 20 to 25% patients overall. Nationwide health centers are coming from a group of health centers with over 500 employees. I think the other spot, and Ron talked about this shift into the telehealth arena and where some of the gaps are right now. It's not only at the startup phase, thankfully not heavy on equipment as much as it was probably a few years ago, but more in just being able to start it up within their own operations and making those shifts to be able to do that. And also the gaps in the reimbursement rates. We saw one report anecdotally from the field that a health center was reimbursed $6 for a telehealth visit, which is just unmanageable going forward. And so that's the kind of stuff that I think we're really looking at, where even local foundations and state foundations can assist right away. And then finally, I think the one point to emphasize is that this is the moment now to really start thinking about what it will look like in 3 months, 6 months, and 12 months, like Malvi said, and to bring in the national groups, whether it's NAC, NATO, others, APHA, other partners who will have that national lens and be able to really think about what are we going to need in this futurist view? Is it going to be the kind of more bringing partners together at the local levels and helping them start to collaborate more, clear some capacity building resources for them? How to, really take that moment for perhaps some big audacious programming and what could be some of the biggest investments some of your endowments may be making. It's a big decision point, we know, for the philanthropy sector of you're fighting one battle on the endowment to keep it whole in a tough market right now, but also how to distribute that endowment in the most needed spots right now. So thank you, Eileen, definitely on behalf of everybody on NAC. We look forward to hearing from our funder colleagues and hearing some of the questions, but I'll pass it back to you.
Well, thank you. Thank you all so much. I know that was a lot of ground to cover in a short amount of time. You all did a great job. We'll now turn to 2 examples that demonstrate how health funders are addressing these unprecedented challenges. I've asked Brenda and Steve to provide some high-level overviews of the circumstances in the communities they serve and the strategies they've adopted to shore up the safety net. Brenda, let's go ahead and start with you.
Thank you, Eileen, and I want to thank our panelists for sharing this information. It's so vital to hear it straight from you and not through the hundreds of emails that are coming into our inboxes from various sources. So I really appreciate your thoughtful overview. I also would like to just extend my well wishes to my funder colleagues. I know that like many of you, we have been spending a lot of sleepless nights and endless days trying to figure out how to best respond. So thank you for all that you are doing in the philanthropic arena. And last, I want to thank my colleagues at Grantmakers in Health. I'm on the board there, and man, do we have a wonderful staff team that has pulled this together quickly. So thank you, Eileen, and your colleagues. I just wanted to share a few thoughts. REACH, like many other foundations, had to quickly pivot and assess our response to COVID-19, but still operate within the parameters of our legal and governance structures and constructs, our 501c3 status or tax status for other foundations, and our various spending limitations and restrictions, and of course, our available budget, all whilst paying attention to the fact that our endowments are going to be significantly hit over time. Fortunately for us, we have a 12-quarter look back to determine our asset value, which helps smooth out these kinds of bumps. And we learned that lesson the hard way in 2008. So if your foundation hasn't already done that, I'd be happy to provide some testimonial to your board about why this is important. First, I want to just walk through a couple quickly the steps that our foundation took, and I don't think these are necessarily unique, but if you are a new CEO or have less experience with this kind of a significant event, and I can only relate a little bit because I was here in 2008, but I can still say it's nothing like what we're experiencing now. But we did learn some lessons that I think are relevant. My first week, about the week of March 13th-ish, I realized I was going to need a lot of flexibility and autonomy from my board and a lot of trust in order to move nimbly and quickly. So my team and I got together. We asked for and received support from our board to respond very nimbly and quickly, and to be able to reallocate any unspent or unallocated dollars within our current annual budget. And this proved to be incredibly helpful. We also had to quickly determine our priorities. And for us, we turned to our existing portfolio of core operating partners. These are 28 organizations in our service area that we have been funding for over a decade with flexible, unrestricted core operating grants. And again, if you don't have that tool in your toolbox, I would suggest this is following this high stress period would be a good time to revisit with your board the importance of having a core operating portfolio. We decided we should focus primarily on our federally qualified health centers and community mental health centers in that portfolio because they are so critical to the safety net. And without them, much of the rest of the safety net doesn't function very well. We also know them, they know us, they're trusted partners, and they were already in our grants management systems, which I also can't say enough about how important that was to be able to deploy dollars quickly, having those known entities that we were working with. We poured over our budget as a team, and I will share with you this was a very critical and painful but necessary process. We typically make about $4.5 to $5 million in grants annually, and I thought going into that exercise, I was really hopeful we'd be able to free up about $500,000. We were able to free up about $1 million, but we really had to prioritize and think about what could be delayed, what work was likely to be delayed in the rest of our portfolio because the bandwidth just wouldn't be there or the workforce might not be there when these folks return to more normal operations. We also had to think about what might be sidelined and who would have to be shifting their priorities, and then what should be protected at all costs, and to also honor our prior commitments to existing grantees and partnerships. We simultaneously to this review process relaxed pretty much every restriction we have on our existing grants. We converted some grants for care connectors, for instance, to unrestricted grants at the last minute. We reviewed our administrative burdens and extended out or dismissed altogether certain reporting deadlines. And I think that that was very well received, particularly by our FQHC partners who were struggling just to keep their heads above water at that time. And I want to say here that, you know, REACH is not in a vacuum. We have amazing philanthropic partners in the Kansas City region and in Kansas and Missouri. And we worked closely with our sister foundation, the Health Forward Foundation, who had already had plans underway to convene the FQHC leadership in our region, as well as we worked with a third local health conversion foundation here, the Wyandotte Health Foundation, and a private family foundation who funds heavily in the healthcare space. And I think it's important here, you know, we have a long history of collaboration. It's a high trust group, so this wouldn't work for everybody. But what we agreed to do as a group of 4 funders was to make a process as simple as possible for this group of FQHC leaders to share with us their anticipated needs over the next 90 days. We asked them to respond to all of us with a very small set of questions, you know, a page or less, and to do that via email, so not using a formal form. They all came in different formats. The 4 of us got together about 2 days after each request came in to evaluate those. And we asked for this request to be in a global format. So for instance, if they anticipated a $1 million operating loss over a 90-day period, we asked them to just tell us that it's a $1 million operating loss instead of trying to guess what each funder might be willing or able to fund and say, you know, REACH, we need 500,000, and Health Forward, we need, you know, 250 or something along those lines. So that was, I think, very helpful too, and it allowed us to move more quickly. And then each of us really used kind of a lean in, lean out strategy. If those organizations were in our current and existing portfolio, or our boards had communicated that they were a high priority, those were where we directed the most funds. And then where we were able, the other foundations were able to offset some of those costs for other clinics that might be more in their geographic region or that served a population that foundation was particularly interested in. So it was by no means an equal, you know, everybody's going to take this and divide by 4. It was very much what can we each do with what we each have as quickly as we could. And then I'll just end on a couple of notes and reflections from our speakers. I think it's really important for foundations to think about what other resources they have to leverage beyond their financial investments, their community investments. That means influencing and engaging other networks that we are part of that perhaps some of our grantees may not be. So for instance, chambers of commerce, working directly with local units of government and other legislators at the state level to be sure they understand exactly what the impact is for low-income, uninsured patients in our community. And for us in Kansas City, that means 2 states that have yet to expand Medicaid. So our federally qualified health centers were already in a very, very marginal situation in terms of capturing reimbursement for their existing patients. And this is only going to exacerbate those very thin margins. And talking to policymakers about that and making that connection between lack of Medicaid expansion in the current state and the safety net's ability to respond adequately in this kind of response, I think is an important thing for us to think about. We also have been thinking about what else we can bring to bear. So if we have consultants, if we have IT, again, chambers of commerce, et cetera. One interesting thing that happened here in our region, which I just found fascinating, was I was bemoaning the situation of our FQHCs on a Chamber of Commerce public policy call. And one of my colleagues with one of the largest engineering firms in the country, actually headquartered here in Kansas City, reached out to me afterwards and said, you know, we build these mobile and, you know, quick setup facilities all the time. Could we help your supported organizations with some drive-up or mobile testing units that we could set up outside of their existing sites? And I said, I don't know, let's find out. So we connected that firm to our state primary care associations and our regional FQHCs, and I believe that at least a couple of them are taking them up on that offer. Another opportunity that came up, which I did not anticipate, is one of our investment managers for our foundation's endowment reached out. I think it was just a mass email to their various fund holders and said they were going to work on a bulk purchasing opportunity with their hospital partners to buy PPE at a reduced cost. And so I reached back out to them and asked if they would consider allowing our FQHCs to participate in that as well. And at least one of our state PCAs took them up on that offer and was able to purchase some additional personal protective equipment at a much reduced cost and probably a quicker distribution and delivered directly to them. So that was something unanticipated. And then I will share just a couple of other things regionally. If you're not participating in a regional response and recovery fund, philanthropy is certainly working hard on that here. And I know many other states, Colorado and others, are doing that. I think that's a great way to help support a broader collective of organizations outside of the FQHCs in addition to the FQHCs. Our colleagues at Health Forward Foundation have developed a child care scholarship program for to prioritize workers, healthcare workers in the safety net here in our region in a partnership with the local Y. I thought that was a really novel approach. Our colleagues in Missouri Foundation for Health in St. Louis are working on a very novel approach to supporting food systems there, for instance. So I think if we get creative and think outside of our usual methods and tools, we can really drive some change here. And to the one of the earlier speakers' points, I think we do need to be prepared over the long term to support mergers, formal affiliations, study and analysis of what a new regional safety net might need to look like going forward, given fewer resources and workforce challenges. So I thought that was a really good point. And I will end on the last thing I think funders can do is really exhibit care and concern and express that in a human way to our grantees. There is always a power differential that is present, and it's up to us to try to minimize that. So I have found just calling people and saying, how are you doing? Tell me how you are. How are you feeling right now? I'm sorry you're having these challenges, has been really well received, and I encourage all of you to do that where you can.
Brenda, thanks so much. Thank you for sharing your experiences and the innovative strategies that you've been pursuing. We'll turn things over to Steve.
Hi, everyone. Thank you. And thank you, Brenda, and to all of our speakers so far. I will be as brief and succinct so we can end with hopefully some questions and discussion. I want to build on what Brenda and other speakers have been talking about, maybe certainly carrying it forward from both a system perspective, but also looking at the individual federally qualified health centers that we're talking about, and some of the speakers have mentioned. They are serving the people that are first to be impacted and the last that will recover from this. We know this. We know that, as we've heard, FQHCs have a long history of clinical care being what Cambia Health Foundation is really focused on, which is whole person care, and really getting rid of those barriers between clinical care and social care, and they are one and the same. And federally qualified health centers have decades of experience in this. And so we at Cambia Health Foundation have been leaning into this over several years with them as trusted partners. We do grant making in Washington, Oregon, Idaho, and Utah. In all of those states, we immediately reached out to each state has an association of federally qualified health centers. So we immediately reached out to them to be able to be discussing how we can work together to deploy resources quickly, efficiently, and equitably. And I think that's the other key piece in this. Federally qualified health centers very often are at the forefront and have committed to health equity and eliminating disparities. They are trusted providers in the communities, and they are ready to respond not only for the emergency needs that we've been talking about, but what it looks like for recovery and resiliency. And so Cambia Health Foundation has been really focused on this, and now is the time that we, I think, all, if not already, really leaning into trust philanthropy and really trusting that these community partners, and specifically federally qualified health centers whose boards are made up of majority of people that they serve, know what the needs are and can be nimble and flexible, but also accountable at the same time. And so we're really mobilizing those resources within these 4 states. So happy to answer any questions after this, but certainly in the states of Washington, Oregon, Idaho, and Utah, we are ready to work both with other funders and with the federally qualified health centers in these states, and welcome talking with anyone about this. And then I'll end with some specific stories. We were first and early on the ground, unfortunately, in Seattle and in Washington, and we were heartened by both the way the community and funders came together, but it also highlighted what is unfortunately at the surface, which is the stigma and this fear that this brings. And so we really worked with our FQHCs, excuse me, to really address that head on. And then so I think this is not a time to shy away from that. It is not a time to make it divert us from what's important at hand, but it's also a time to recognize and reinforce the fact that equity is extremely important and is not always there within the healthcare system. So I'm going to end on that. I'm going to end on the fact that I just want to say I'm proud to work with everyone on this call, and we're going to do good things.
Great, thank you, Steve, and thank you, Brenda. I know, again, I asked you to do a lot in a short amount of time, so I appreciate your willingness to share and to be as concise as you have been. And it is really helpful to learn about the steps that you've taken. We're now going to turn to our Q&A. I see that we are almost out of time. I know that most of our speakers can stay on the line a little longer, so if participants want to stay on, we will try to address some of the questions that have already come in through the chat box. If you have some questions that you'd like to pose, please enter them into the question panel. I'm also going to, while you're sort of thinking about questions to ask, I'm going to launch a quick poll. And I will tell you, I've never done this before, so hopefully it works. But in the meantime, while participants are responding, I'm going to go to some of the questions that have already been submitted. And I think most of them are for the NAC staff. And I address this to all 5 of you if you just want to choose who wants to respond. We had a question early on asking for some more information about how dental services have been impacted, and if you've seen dental staff be redeployed into primary care workflows. I think, Dr. Yee, that might be for you.
Sure, Eileen. Yeah. So dental staff, again, it's geographically based, but the health centers that are really being stressed and have high flow and surge situations with possible COVID patients or respiratory patients, they have been charged by the governors to stop doing regular dental procedures. So that would be regular dental care that only take an emergency. So what health centers have done is they've shifted those staff. Because a lot of the dental folks do have patient care, they understand patient care, they're the ones manning the phones and actually making calls to patients to see how they're doing, whether they be chronic care medical patients, but also dental patients who have had their care plans interrupted. So they're following up with them, making sure that they're able to eat and go through normal functions of daily life without having their work finished. So they are shifting over, and some health centers have laid off some of their dental staff. The smaller health centers that have not been able to flex and reassign them are doing that, but most of them are shifting to virtual visits, phone calls, and using them in other ways to screen patients, to help out with frontline medical care. So that's what's happening with the dental staff, as well as a lot of the behavioral health staff are shifting in the same way.
Great, thank you. I think this question is probably for Jennifer and Susan. If you can speak to whether or not any federal dollars have been set aside for free clinics that are, of course, not part of the FQHC network. I think you both may need to
Jennifer, you're
unmute
on
your
mute.
lines. Yeah, I'm sorry, I apologize. I think they may have been muted for you, so you might not have realized that you were on mute.
Eileen, this is Jason. I'll jump in here unless Jennifer and Susan do it. The money set aside for the FQHCs has been very specific to the FQHCs. And there may be other categories, especially within the PPP program and the SBA loans, as nonprofits that the free clinics may have access to. I see that Jennifer is unmuted now, and I'm sure she could build off that some.
No, that was exactly it. Thanks for stepping in, Jason. I don't think, to the best of my knowledge, there is a specific set aside for free clinics, so they would presumably be eligible both for the SBA loan program and for that $100 billion pot of funding. I should say, in addition to free clinics, many of you may be aware there is a type of health center that is called a lookalike clinic, a lookalike health center that operates essentially exactly as a health center but does not receive federal grant funding. They have to follow the same policies and procedures. They have the same makeup, and their hope is obviously ultimately to be eligible for the full federal grant funding. They also are not eligible at this point for that specific $1.32 billion set aside that health centers got. So those lookalike health centers, of which there's, I think, about 84 of them in the country, also do not have a specific pot of funding. So they would also be in that same pool of trying to get from the $100 billion or from the SBA loan. So there's certainly places that are still in need of additional attention.
Thank you. I'm going to close the poll so that folks can hopefully see the results. I think if it's not showing up, I'll just sort of quickly share. So we had about 52% of participants responded to the poll. And as you can see, it's pretty evenly split between respondents who are increasing grant funding to support the safety net and those that are currently considering it. So I'll give people a few more moments if you would like to add any additional questions into the question box. And in the meantime, I am going to try to launch a second part to our poll to ask whether or not your foundation is offering no or low interest loans to safety net providers. And of course, if you have any additional questions, please enter them into the question panel. Again, we're at time, but I think the speakers have agreed that they can stay on a little while longer if there's any remaining questions. All right, I don't see any more questions coming in, so I'm going to sort of, although we've only had about 40% reply to the current poll, I'm going to go ahead and close it. And folks can see the results. Most folks are not providing loans, and there is a small proportion of people that are considering doing so. So I think with that, we have come to the end of our time together. I want to thank our terrific panel of speakers, Ron, Malvise, Jason, Jennifer, Susan, Brenda, and Steve. We really appreciate your taking the time to be with us today under these very challenging circumstances. And I say to our participants, if you have any additional questions or comments, please feel free to contact me. And thank you for participating in today's webinar. GIH is continuing to develop programming focused on COVID-19 response, and we really urge you to share your priorities with us. We look forward to your continued participation in these shared learning experiences. Thank you all so much.
Thanks, Eileen, and thank you, everyone.
Thank you, everyone.
Bye-bye.
Thank you.
Thanks, Eileen.